Now we'll move rapidly on. I see Professor Paul Chan there ready to talk. Paul is the chair of the Department of Microbiology at the Chinese University, a good friend of ours in the emergency department, especially at this time with all the challenges that COVID has brought. Paul also serves as the Deputy Director of the Stanley Ho Centre for Emerging Infectious Diseases, which clearly is in its forefront at the moment. And we're looking forward to hearing Paul talk for the next few minutes on diagnostic methods for COVID-19 and what we need to learn. Paul, thank you again, and all yours.
Thank you very much. It's really my honor. I'm just figuring out to share my screen with you. Can you allow me to share?
You should be okay now.
Oh, okay.
Brilliant. Oh, you've got the.
Okay, you can see my screen now.
We can.
Okay,
We're not seeing the full screen. That's the only thing, but it's fine. It's fine. Thank you.
You are not seeing the full screen.
It's the notes display, but that's fine. Carry on.
Is that better?
Perfect. Thank you.
Okay, it's really my great honor to share a small talk with you today. So I will focus on the diagnostic aspect of COVID-19. So that's the electron microscopy. With that, you can see really the whole coronavirus. And the Emerging Infectious Disease Journal pick up a cover to tell people what is a really a coronavirus means. So you can see here. Sorry, let me just move this. Okay, you can see this really shows what is corona. Okay, just summarize the diagnostic approaches for detecting viruses in general. So on one hand, we can detect by using direct detection. That means including you just want to see the virus, put it under electron microscopy, and then you can have the beautiful image of the virus. Or you can detect the protein or antigen assay people may refer to. So this could be a very simple test kit. You can do it in the office, just like a patency test. Now for direct detection, that means you do not amplify the amount of virus or protein to any extent. So the sensitivity is limited mainly by the sample, how good you are going to take the sample. So the other aspect is amplification. So we can amplify the virus using conventionally to grow the virus for a few days, then you can see what happened in the cell culture. Obviously, this requires BSL-3, which is not that widely available. So for coronavirus 19, not much isolation was done as a routine. And the most commonly used method would be to amplify the nucleic acid using PCR. I think this is like a routine nowadays as the method of choice to detect COVID-19 infection. Just a quick summary of the PCR concept. You have a nucleic acid and then you design primers to amplify. At the end, you get 10 to power 9 copies of the product. And then you can detect them using real-time machine. I think most people will use this method now. And if you look at this signal, actually those what we call the CT values, the threshold cycle. That means after a certain number of amplification cycle, you see a signal which is strong enough for you to say this is a positive reaction. So that's why the CT value of a smaller value, meaning that the sample contains higher concentration of starting material, that is the virus, because you only need maybe just 10 cycles, then you can see a confident positive signal versus maybe 40 cycles for some samples with less amount of virus. Now this provide us a very, very sensitive method, super sensitive. And this is also the trouble it causes. It may cause false positive, not because of this procedure itself. It is because maybe when you take a sample, there's a little bit jump over of the specimen to another specimen, or even more commonly within the laboratory, it's just the reagent, the apparatus that you are using accidentally cross over a little bit with the next specimen, then you may have false positive. As you are aware, in Hong Kong, in the last week, we really face a problem of this false positive generated probably in the laboratory. Okay, antigen test is now getting more acceptance, and I will elaborate a little bit more. So you detect the protein of the virus using a small machine, or even without any machine. You just put a drop and then you can detect it. Basically, the principle is that you need to have an antibody that can recognize the protein of interest. So these antibodies are made by different means, from a mouse, from a rabbit, and then you incorporate into an assay. So the reliability or the performance of antigen detection assay depends critically on the quality of antibody. So there are many ways to make antibody. Some people make a very good antibody, but others may not. So in general, antigen tests, the performance is quite brand dependent. So you need to find the right company to give you the good antigen assay. Unlike PCR, for PCR, people use the same set of material and not much on the brand of the enzyme or the primer. But for antigen assay, you really need to rely on the brand because they have their proprietary antibody that they have developed to catch the protein of interest. Now, in general, antigen detection assay is less sensitive than PCR, and it tends to generate more false positive results. As you can see here, there are only a few steps and not much cleaning in between, especially for those that can be completed within 10 minutes, 20 minutes. There's not much cleaning in between. So this is something you want to be aware of. Okay. And at the moment in Hong Kong, we do not have regulatory control on antigen assay. So you can buy it in a pharmaceutical shop or maybe even supermarket. And this is really something you need to be aware of. So because of less sensitive and the chance of false positive, in general, we do not recommend antigen assay for individual diagnosis. But of course, there are a lot of exceptions to you really want to have a rapid assay. Okay, in general, we do not recommend for individual diagnosis, but it can be used to assess a group of people, for example, a building suspect of infection transmission, then you can do antigen tests, and then within 1 hour, you know what kind of problem that you are facing. And for each individual person, you will have a PCR test to back up. Now, the emerging application of antigen tests nowadays is for post-vaccination purposes, not to assess the vaccine response, but for maybe as a part of the entry requirement or to relieve quarantine. So for those people who have received full course of vaccination, and some country may want to, on the top, to add an antigen test at the border so that to improve their confidence that these people can receive a shorter duration of quarantine or even waive the quarantine. Now, as you know, in Hong Kong also, people are using antigen tests to visitors to hospital or elderly homes for those with vaccine or without vaccine. And also for hospital authority, we are applying very soon for unvaccinated healthcare workers. They want them to have a repeated antigen test. Now, in all these situations, I want to bring out one point for your consideration is that we are actually testing populations of low risk of infection because they have been vaccinated, they are a healthy person, and they don't have history of exposure. So they have a very low prevalence of infection. Now, in that case, the positive predictive value, that means when you receive a positive result, what is the chance that the result really indicate a true infection? This positive predictive value will become very low because of the testing population itself. Sorry. So we need to be aware of false positive in these people, and we want to have a logarithm to manage those positive results with bearing in mind that there could be false positive. Okay, so sometimes when you apply this test to this kind of low prevalence population, the chance that you have false positive is actually higher than the true positive. So this is the thing that we need to prepare for when we apply antigen tests in such situations. Okay, that's so much about the commonly used tests, antigen and the PCR. Then let's go back to the specimen. To take a good specimen is equally important as to choose the right testing method. So where is the virus? What kind of sample would be good for diagnosis? At the very beginning of the outbreak, we tried to recruit 14 patients from a hospital, 6 male and 6 female. So we have around 300 samples tested, and with a purpose to see where do you find the antibody, the virus. Okay, I think you're all familiar with this. Respiratory tract would be very good, and also GI tract as well. And then blood seems to be not very sensitive in contrast to SARS-CoV in 2003. Blood is not that good for SARS-CoV-2. And urine, all of them were negative. So with this, we then also take a meta-analysis that was last April, try to see what happened in other centers, what kind of specimen is good. So as expected, a pooled oropharyngeal and throat swab would be the best and very similar to nasopharyngeal swab. And then sputum, if those people have. So these could be the best specimen, most sensitive that you want to use. Nasal swab is not as good as these. So nowadays, people are also talking about the nasal swab that in the Hong Kong use for people under quarantine. And of course, how you take a nasal swab will cast a lot of differences, whether it is just a simple anterior touching or it is really going deep into the nasal mucosa. Okay. Saliva sample also appear to be less superior in sensitivity. And then stool sample, although we find virus from stool, but according to this meta-analysis, stool sample is not very sensitive, just halfway. This is not unexpected because a stool usually contains a lot of inhibitor to PCR reaction. So sometimes even if you have the virus there, it may not show up a positive result. Okay. So of course, self-sampling is an attractive option for COVID-19 because of many simple reasons. So we try to take a look at the performance of the deep flow saliva, which was used very widely in Hong Kong because people can take it at home. And here we include 2 hospitals, the Prince of Wales and UCH. We have 50 confirmed cases, and then we try to take serial samples from these confirmed cases, altogether around 500 of them. And we try to compare the deep flow saliva performance against what we call the gold standard, the pooled nasopharyngeal and throat swab, and also sputum. So these respiratory specimens, we want to compare the performance. Now, the first data I want to show you is in terms of when, that means when was the patient sampled after onset of illness. If overall, if we sample them within the first 22 days, you see the sensitivity of these three specimens, the best will be sputum, but not everyone can produce sputum, right? And then followed by the nasopharyngeal swab, and then followed by diffuse saliva. Now, if we segregate them into earlier days, 1 to 5, and the middle and the late, 10 to 15, after onset of the illness, you see the differences become more obvious for later samples, obviously, because they tend to have lower amount of virus during later samples. So bearing in mind, if we take sample late, then the false negative rate of certain specimens, such as diffuse saliva, could be high. Okay, the next we want to take a look at home. So what kind of patient are they? So for clinical severity, if we merge them together, you can see this diffuse saliva is a little bit less favorable than the other two respiratory specimens. And then if we divide them into asymptomatic, moderate, critical, and severe, you see the difference is bigger for the group of asymptomatic and mild infection. For those severe infection, you do have even a better result for saliva than nasopharyngeal swab because they have very good viral load. So the nature of specimen probably does not matter too much. But for the asymptomatic, you see sputum is good, nasopharyngeal swab is good, but saliva is really less favorable. And then we obviously observe a correlation between sputum and diffuse saliva, the concentration of virus that we can find. So you can imagine actually diffuse saliva is like a poor quality sputum. So if people can produce sputum, we will encourage to collect sputum rather than saliva. And then after all, we find that the false negative rate of diffuse saliva can be as high as 30% overall, and even higher for people who do not produce sputum. So another self-collection possibility is use gargling with saline. So just turn it quick. You see the blue color represents saliva and the red color represents gargling. Using different methods, they are very similar, no statistical differences. But saliva is slightly better than gargling. Okay, so gargle is acceptable, but saliva is a little bit better. And then we also have developed a method to collect nasal epithelial lining fluid from children, and basically to put a strip into the saline wetted strip into the nostril, and then hold it for a minute, and then take it out, and then try to elute the fluid and try to detect the virus by PCR. I have a video, but I think time may not allow, so I just skip the video. So the result is that compared with diffuse saliva, this kind of nasal epithelial lining fluid gives you a very good sensitivity, 94%, actually better than diffuse saliva. And the sample is very stable over 3 days, so very good method as a self-collect sample for older children. Okay, I just want to mention briefly about stool. And we did a meta-analysis, try to see the performance of stool as a diagnostic test. If we analyze by patient for these studies, the diagnostic sensitivity is only 43%. So if you take one sample, you better take a respiratory rather than stool sample. Now for patients with digestive symptoms, then the sensitivity is better, 77%. But for those without symptoms, it is only around 50%. Okay. However, for certain situations, if you cannot take respiratory sample, stool may be considered. We have experience of using stool sample for mainly children over 1 year, and we have tested 17,000 samples with a positive rate of 0.13%. And these are mainly children coming back from high-risk area and also those who are suspect to have been exposed. So in compare with other programs, it seems that using stool sample, at least for children, give you a quite acceptable positive rate. So this can be accepted. And one thing to mention is that most of these positively infected children, they are asymptomatic. And here are the viral load of a stool sample compared with adult saliva sample. The viral load is a little bit lower, but still within a very good margin for detection. Okay, so stool test in simple is that for individual diagnosis, actually there's some inhibitor problem, but for children, they tend to shed the virus in stool for a longer duration than adults, so maybe good for children. But repeat testing is necessary if you find a negative result, because we know that you need to repeat. Okay, finally, a problem of persistent PCR in a lot of our patients. And the recent study on these MBA people, and they try to answer the question whether these prolonged shedders are really infectious. So in this, I would like to bring in the concept of subgenomic RNA testing. Now, in the conventional diagnostic PCR, we target the genomic RNA, which is inside the viral particle. But when the viral particle going into the cell, when it replicates, actually it will release a lot of subgenomic RNA, which has a different, just opposite sequence as the genomic. So we can design a PCR to target this subgenome RNA. The purpose is to differentiate whether the specimen is containing active viruses, as indicated by this spectrum of subgenome RNA that are being produced during the process of replication. So in opposed to perhaps maybe just the fragmented genomic RNA, the dead viral particle that are actually contained in the sample. So using subgenomic RNA, first, this is the culture positive specimen. And this is the CT value of diagnostic PCR, 16 to 20. And then these are the color, all represent positive subgenomic result. And then for culture negative, we also find they are positive for all the subgenomic RNA PCR. That means that subgenomic RNA PCR can actually be more sensitive way to detect infectious specimen. Now for those culture negative and has a lower CT value, a lower viral load, higher CT value, you see the cross represent negative subgenomic PCR result. So here indicating that they are actually non-infectious. So although they are positive by diagnostic PCR, they are non-infectious. And here are examples of serial sampling of samples from the same patient, upper respiratory tract, lower respiratory tract, and stool. And all these samples were labeled as positive by diagnostic PCR, for example, up to day 13. But if you use subgenomic PCR, this sample will be regarded as infectious only up to day 8. And for the stool sample, diagnostic PCR will be positive up to day 13, but actually none of them contain subgenomic viruses. So they are not infectious. Similarly, for the other interpretation, say for this patient have a very prolonged shedding, 32 days, still positive by diagnostic PCR. But in fact, if you do subgenomic PCR, you know that the infectivity was only up to day 11 or day 13. So perhaps subgenomic PCR can help us to clarify some of the information when we want to really understand the activity of the virus. Okay, finally, I would like to thank the funding bodies and my very nice collaborators who contribute to the data that I've presented. Thank you very much. This is the diagnostic center we are running at the moment. Okay.
Thank you very much,
Thank you.
Paul. If I can ask you just to hang on for another few minutes, just till we do our roundtable discussion. But thank you, that was fascinating. It as always, makes me realize that the gulf between the press reporting a positive and a negative is clearly far more complex than that, which is the challenge for all of us, trying to convey that information with the public.